Uh, really appreciate the invitation, opportunity to deliver keynote address in this prestigious conference. And congratulations to the team and LGS for a very successful event. What I will do in the next few minutes is to give an overview of ovarian cancer, particularly epithelial cancer, and highlight on the changes that have changed the paradigm in the management of ovarian cancer. You all, by way of your specialty, would happen to diagnose ovarian cancer quite frequently, and therefore it is of concern to this audience also as to what is happening in the field of ovarian cancer. And these are the statistics from Global 20 and from our own country. And in terms of incidence, you can see that the figures are still high. Almost 6% of all cancers diagnosed in females are ovarian cancers. And in terms of incidence, actually, both today it ranks third in India also. At NCI, it continues to form about 7 to 8% of all the cancers to be diagnosed in females, and the ovarian cancers are about 120 onward. You can see the numbers are going up. Only about 50% of these patients are able to undergo major surgeries, and that is for various reasons, socioeconomic factors, stage experimentation, fitness for surgery, etc. So when we think about ovarian epithelial cancer, it's not one entity. Majority would still be high-grade serous carcinomas, but quite frequently we do see other histological types like low-grade serous carcinomas, clear cell carcinomas, endometrioid, and leucinomas. And when we approach these patients for diagnosis and management, we lump together all three: epithelial ovarian cancer, fallopian tube cancer, and primary peritoneal cancer. These three are similar in terms of biology. In fact, we must be aware about the hypothesis of ovarian cancer originating from the cells in the female end of the fallopian tube. So, you are all aware about how these patients present, and there is no particular specific symptoms, and they are very vague. And that's the reason they come very late. And it's often the first ultrasound that you do in the clinic, which raises a suspicion of an adnexal mass and ascites and maybe some deposits in the peritoneum momentum. And then you order CA-125, it comes right, and then you start suspecting epithelial ovarian cancer. These patients do need a CT scan of abdomen, pelvis, and chest. Ultrasound alone is not enough. CT chest is also important. Frequently we don't do CT chest, but it will tell you if there is an extra abdominal disease. Or like invasion of the rectum or the bladder, and MRI of pelvis contrasenas is a very valuable addition. Because you will be assessing this patient from the point of surgery, and therefore an adequate imaging, cross-sectional imaging is very vital. So, the historical diagnosis would be at the time of surgery when you open this patient up for removal of the adnexal mass, or you may have to send samples to diagnose them. It is usually in the form of acidic fluid cytology, or cell block, or a laparoscopic biopsy, or the CT-guided core biopsy from momentum. So, when you approach these patients, before you plan anything, I would like to stress that you must insist on histological diagnosis. The initial sampling could be either the fluid or an omental core biopsy. It is usually not required to directly hit the adnexal lesion. And the first input that you must get from the lab is it epithelial cancer or is it non-epithelial cancer? Most of the labs in Nagpur simply are now equipped with immunological immunohistochemistry. They should be able to tell you this. Once they tell you it's an adenocarcinoma or it's an epithelial malignancy, then the next bifurcation is whether it is gynecological origin, uterine origin, or urinary origin, or non-gynecological. Frequently, patients do have hook and birth, and it will be important to differentiate. So again, if you give them cell block or some kind of a tissue sample, the pathologist will be able to tell you whether it's gynecological epithelial cancer, and then only you can proceed. So I was telling about the types of ovarian epithelial tumors. They are not only distinct in terms of immunology, they are biologically different. Their genomic makeup is different. Their clinical behavior is different. The response to therapy is different. When we talk about ovarian epithelial cancer, generally we are referring to a high-grade serous carcinomas. Now, clear cell and endometrioid do occur from time to time, and they are different in terms of their behavioral aggressiveness and response to chemotherapy. For low-grade serous carcinomas, generally we don't give any adjuvant chemotherapy. There are now a couple of new drugs which have been developed for low-grade serous carcinomas. Mucinous, you have to exclude GI memory, and they don't respond very well to the traditional chemo combination that we use for serous carcinomas. So all this is possible if the pathologist tells you what kind of level subtype it is in the outset. And then you have to do the staging. Of course, the staging will depend on clinical assessment and imaging. Unfortunately, most of our patients come in advanced stages, as you can see.
Sorry to interrupt you, sir. Please, everybody is requested behind to please be seated and please be silent. Thank you.
So you can see that the survival is directly correlated in this stage of presentation, and it's quite dismal in most of our patients. Less than 30% of our patients will make it to 5 years or more. So how do we treat these patients today? So let me just narrate you this standard of care for these patients. Typically after symptoms and diagnosis confirmation, either they are candidates for surgery or they are not candidates for surgery. So either you operate them or send them to medical oncologists for chemotherapy. Whatever is the sequence, and then once they have done the surgery, finished all 6 cycles, then they will be on follow. Most of them would recur. There have been attempts to add further to this treatment of initial surgery, upfront or interval plus chemo by giving something in addition, either doing a second loop laparotomy or giving something inside the peridural cavity, giving some kind of maintenance. So far it has not helped. So usually patients are observed till they recur clinically, and then they are offered later lines of chemo. So as long as they respond to chemo, they do well, patients are treated, but unfortunately most of them would die of the disease. There have been attempts to subject them to a second cytoreduction. So patients who had a good cytoreduction upfront and they responded well to the treatment and they enjoyed a long disease interval and they have limited disease at recurrence, which you're confident you can remove completely. These are the patients who they would benefit by second cytoreduction. So in fact, most guidelines now say that upon recurrence, see to it that the patient can be offered second cytoreduction and they are eligible for it, to offer it, followed by second or third levels of chemo. So the first decision which you make in a new patient is whether the patient is surgical candidate or not. Of course, the fitness of the patient, most of these patients would be hypoproteinemic, they would be anemic, they would be bedridden, they will have a high risk of thromboembolism and resectability of the disease. So if the patient is a surgical candidate, the next question is, can we do an optimal debulking? And the question optimal, the word optimal has now been replaced by complete. Can you do complete cytoreduction? Yes or no? If yes, go ahead with surgery. If no, go ahead with neoadjuvant chemotherapy. And once you have done optimal debulking, then patients are put on adjuvant chemotherapy. You will now try to see if you can give the chemo in a different way, where instead of giving IV, can give it intraperitoneally or giving it more frequently in a dose-dense fashion, plus minus addition of some biological agents, whether that improves survival is currently subject to clinical trials. In case you opt for neoadjuvant chemo, then after 3 cycles, the patients usually respond. The hepatitis rise up, the performance status improves, the nutrition will up, so you can offer them improved cytoreduction, followed by for the chemo. And then there is no consolidation, it's a question of, it's an open question for the surveillance. So why neoadjuvant? If the patient, the disease is confined to the abdomen, frequently you will find such things inside the abdomen. The patient is studied with numerous deformations of the disease, which are physically impossible to remove. Or CT scan would tell you unresectable liver disease or medicinal nodes, supraclavicular nodes, there will be fusion, ectocritic nodes, axillary nodes where the patient cannot be offered a complete site reduction. But this outcome of surgery, even after 5 to 6 decades, remains the only deciding factor in terms of survival improvement. And it has been seen number of times in number of trials that a complete site reduction to 0 millimeter residual disease is the major factor in deciding the outcome of the patient. And you can see that even between less than 10 and more than 10, the survival curves are different. So the goal of surgery is not to just cross the site reduce, but leave no visible residual disease. And then trials addressed whether it is good to do operate surgery, whether allow them to have chemo and then do increased site reduction later on. Both the approaches are equal. So therefore, either way you can select your patients. So how do you select these patients? Based on the imaging finding and the patient factors, the most important points to be remembered here, as this was a consensus conference of the European Society of Gynecological Oncology, that the decision must be taken in a multidisciplinary setting. It is difficult to decide in isolation whether this patient can be subjected to surgery or not. Complete tumor resection should be the goal, and only when you are confident that complete surgery with no macroscopic visible disease appears feasible, that primary upfront surgery should be offered. Otherwise, the patient should be sent for initial chemo followed by clinical site reduction. And then, if you have patients like diffuse infiltration of the root of small bowel mesentery, diffuse carcinomatosis involving the stomach, duodenum, pancreas, vessels, supradiaphragmatic disease, deep abdominal metastasis, that these patients should be sent for initial chemo. So the surgical techniques you are better versed than me. Either way, so okay, open or minimally invasive, intact tumor removal, adhesions, washings, biopsies, ventrectomy, lymphatic evaluation, removal of all visible disease, adequate upper abdominal disease removal is important. So unfortunately, in spite of all this, recurrence is the rule. Now, the main thing to be remembered from surgical point of view is quality of surgery. And now there are quality audits in institutions to see if the center is doing well in terms of completeness of the surgery. So, most of the patients, like our patients, large volume advanced disease would recur, even small volume advanced disease would recur, even highest limited stage disease, lowest limited stage disease, about quarter of them would recur. So therefore, we have to improve upon subsequent therapies that we can offer to these patients. So, surgery can be offered. There are a couple of trials which prove that appropriately selected patients can be offered second surgery, and you can refer to these trials. They lay down the patient selection factors, and if you do have such a patient, yes, the surgery would be helpful. So, what can we do to improve the outcome further? Can we influence the stage of presentation? No. There are no effective screening methods to screen for early diagnosis of OD, except those patients who are BRCA1 or 2 positive, where you would be screening them with pelvic ultrasound and C125, even those methods are not accurate. So, optimal site reduction remains the patient's incidence level. But you can certainly control the quality of surgery and appropriate patient selection. There are no biomarkers which patient will not respond to chemotherapy. And there has been no effective consolidation or maintenance or preventive maintenance so far. People have tried to give chemo in different rates, the outcome has not been much different. You must have heard about HIPEC, where the chemos are instilled inside the abdominal cavity with a high hyperthermic solution. It is still not, there is no sufficient evidence to practice HIPEC routinely, except in centers who are doing clinical trial and who have experience to do HIPEC. HIPEC is still not ready for community practice. What has happened on the positive side is development of effective maintenance therapy. So let me take you to the basics of cell biology. Normal cells do undergo DNA damage in response to different stresses, and there is a well orchestrated mechanism inside the cell which involves so many of these genes and their proteins which repair the DNA and restores the integrity of the DNA to its original constitution. And this is called as homologous recombination. This mechanism can be targeted therapeutically. The genome atlas of various cancers have highlighted number of genetic events that occur in ovarian cancer, and you can see that BRCA1 and 2 represent the most common genetic events. So there is an enzyme called PAR which can repair the DNA breaks. In a normal cell, this enzyme with a homologous recombination mechanism would restore the DNA and the cell would be able to survive. However, in a cancer cell, if the PAR is inhibited by a drug and the cells are lacking recombination mechanism, they would die. And this has been exploited by the university to develop a drug to target PAR. So we have now tests to identify if the cancer tissue are lacking in these mechanisms by doing what is called as BRCA1/2 testing and HRD testing. And it turns out that more than 50% of our patients would have such a defect, and therefore most of them would be candidate for such an approach. So there is a growing list of drugs called PARP inhibitors, which have come in a big way as a maintenance therapy in ovarian cancer. A number of them are now FDA approved and available even in our country. So these are the landmark trials which have tested maintenance inhibitors with PARP drugs, PARP inhibition, and all of them are positive trials. So typically they are given for a couple of years after the surgery plus the chemo is over, and all of them. So it depends on the availability of the molecule, you can select any one of them. Even in a relapsed setting where you treat these patients either with surgery plus minus chemo, you can again put them on second maintenance with PARP inhibitors. So maintenance PARP in addition to the surgery, complete surgery, chemo, and maintenance PARP inhibition is a new standard of care in appropriately selected patients based on BRCA status and other tests. It prolongs survival. It also has now a potential impact on subsequent therapy. Since these patients will be living longer, they will be again eligible for subsequent aggressive approaches like second cell reduction and further chemotherapy. So there are tests now available, and so typically now we have started sending the tissue for BRCA testing. And in case the tissue is negative, we send the blood for germline testing. And if BRCA is mutated, then these patients are offered PARP inhibitors after they complete their initial therapy. And there are different HRD panels which are available even in our country, which can test all the genes involved in that recombination mechanism and tell us whether the patient will benefit by PARP inhibition. So this is how now the new layout of the treatment would look. That at upfront diagnosis, in addition to tissue biopsy, ISA, we will be ordering BRCA and HRD testing. We will be offering surgery, chemo, maintenance with PARP inhibition. Upon relapse, offering again surgery, plus minus chemo, and again PARP inhibitors. Here, before I conclude, I would like to highlight some novel approaches that will also being developed in ovarian cancer, ovarian cancer. One is, now it all depends on how the patient comes and what the infrastructure is still available and they will be able to do a successful surgery. People are now trying to look at whether there is a genetic makeup in the tumor tissue which would decide whether the surgery would be successful or not. And there is one such TGF-beta factor. If it's activated, it's unlikely that the surgery will succeed in spite of appropriate selection of patients. So the people are now trying to see if they can bifurcate the surgical decision based on TGF-beta activation. And then you can remove the disease only what is visible to you. You cannot remove the disease which is not visible, or which is not adequately visible. So there are novel imaging techniques like single wall carbon nanotubes which can image the disease, and even nodules less than 1 millimeter can be visible to the surgeon's eye. So it would improve the thoroughness of the resection. And then harnessing the body's own immune system to target the disease. There have been antibodies to overcome the immune suppressive disease. It has worked well in a number of other cancers. It will yet to work sufficiently in ovarian cancer, but its trials are going on. There are other molecular targets under various clinical trials. hypoxia, targeting hypoxia. You must have witnessed that these are large tumors, they are necrotic, so there is a lot of hypoxia happening in these tumors. So scientists are now trying to target hypoxia and certain other receptors like polycytic alpha expression. And they are trying to make up antibody drug conjugate where the antibody will take the drug to the cancer cell and they will release inside the cancer cell. So number of such things are going on. So finally, after the initial discovery of platinum Taxol way back in 95, for 20 years nothing happened to the field of ovarian epithelial cancer. And suddenly from 2005 onward, now the field has really progressed in the direction of maintenance, surgical principles, and therapies. Thank you.